Hi, you all welcome to this presentation, which will be given by Professor Sally Kendall. And I would like to introduce dear Sally. She's a professor of community nursing and public health in University of Kent, UK. She is now the chair of European Forum for Primary Care, and she's co-editor-in-chief Primary Healthcare Research and Development. Her interests are wide-ranging, including patient and public experience of health and healthcare in the community, public health in relation to the children and families, and implementation and application of health policy into practice. She has supervised more than 22 research students and externally examined more than 20 PhDs, including internationally. She holds a strong belief in working in partnership with parents and patients and understanding their needs to inform research and practice. Much of her academic work has focused on the experiences of patients and families, most recently, the experiences of women in Ukraine of perinatal mental health issues. She developed the TOPS tool for measuring parenting self-efficacy that is now widely used nationally and internationally. This has led to research with Aboriginal communities in Western Australia, where she is an adjunct professor. October 2019, she was diagnosed with the breast cancer and became a patient during the COVID-19 pandemic, an experience that has been both a personal struggle and very enlightening. Now, Sally will make her speech titled "The Patient Experience of Breast Cancer During COVID-19 Pandemic, Lessons from Integration of Healthcare and Task Sharing in England." Please, Sally.
I'd like to share with you this afternoon the patient experience of breast cancer during the COVID-19 pandemic. And I'd like to explore the implications for integrated primary care. So I'm really pleased to be here on behalf of the European Forum for Primary Care. And just so you know, this isn't really a scientific paper. It's much more of an exploration, a story of my experience during the COVID pandemic of being a breast cancer patient. So the importance of being a patient. My aim today is to show through my own experience the meaning of integrated primary care through a personal and national crisis. What is the in-depth experience of a breast cancer patient? What was the impact of COVID-19 pandemic on the experience of being treated for breast cancer? What are the key factors in the patient journey during a crisis that can make a difference? And what does integrated primary care mean for a breast cancer patient during a crisis? This paper is really a counterpoint to the importance of being a nurse, a paper by Anne Oakley, medical sociologist, that she wrote in 1984. That paper made a huge impression on me as a young graduate nurse, and I intend to use my own experience as a patient and as an academic nurse as a lever into a deeper analysis of what really matters, the truth about being a patient. As my title implies, I want to explore how important for the patient the sense of being cared for, looked after, loved can be, especially during a crisis, and how in the 21st century we can overlook these qualities that can also be the essence of healing, the art of caring, alongside excellence in clinical practice, and how this can contribute to integrated primary care and integration for a patient. So what is integrated primary care? I've tried to lay out in this matrix some of the elements of integrated primary care that come from the literature. But I think centrally, the idea of providing services that are integrated is to impose the patient perspective as the organizing principle for service delivery. And by doing that, integration is the set of combined methods and processes and models that can seek to bring about integration of services based on the patient experience. So I just want to give you a rundown of what my journey was, and I'd like to go into some of these in more detail as we go on. But when I noticed the change in my right breast, I found myself at the entrance of a maze, of a labyrinth of future appointments, meetings, treatments, all sorts of things that was completely new to me. And I found myself being lost in a maze of tunnels that I couldn't find my way through on my own. And this started by noticing the changes in my breast, and went through consultations with my GP, with my breast care nurse, diagnosis, appointments, biopsies, my mastectomy, something called axillary web syndrome that I'd never heard of, survival estimate, insertion of a PICC line, chemotherapy, hair loss, neutropenic sepsis, radiotherapy, physiotherapy, scar therapy, and now letrozole and bisophosphonate treatment for the next 5 years. And alongside with this, I had psychotherapy. And how do you integrate all of this into a sense of self? I'd like to just remind us of the numbers during all of this. So these figures are based on UK figures from 2015 to 17, where we had 55,176 breast cancer cases, 11,399 deaths, a survival rate of 76%, and 25%, more or less, of breast cancer cases were actually preventable during that time. And if we look at the global numbers, you can see if you look at the pink sector of the pie chart, this represents breast cancer. And if you look at the bottom figures for women, you can see that globally, around about a quarter of all cancer deaths for women are from breast cancer, and 15% of deaths are from breast cancer. In the UK, we undertake a cancer patient experience survey, and this survey shows here, as you can see, quite a high percentage of overall experience, around about 88%. And these data are interesting, but they're also a little bit distorted by the fact that the majority of the respondents tend to be white older men. So it hides some of the experience of women behind that. And it also hides the more sort of in-depth experiences that women have. We also have a set of protocols that drive breast cancer care, and this is from the NICE 12 protocol from 2020, which is also interesting because it really lets us know about the 2-week rule. But we also know that patients and primary healthcare professionals have slightly different perspectives on that 2-week rule. So for the patient being referred within 2 weeks, they want to really, or we want to be told that we don't have cancer. And we want to know that quickly. And within 2 weeks, it feels like a fairly rapid turnaround, although it also can feel like an eternally long wait. And at the same time, the health professional wants to have that, make that rapid referral within the 2 weeks, but they don't put so much emphasis on the importance of the communication with the patient during that time. And this was found in the study from Cornford et al. In 2004. Now, this study in the Lancet has shown us very recently what the impact of COVID-19 could be on deaths from breast cancer through a modelling exercise that they have undertaken. And we can see from these figures that from March the 16th, which is when the lockdown started in the UK, they have estimated that there is likely to be between 281 and 344 additional deaths from breast cancer. and that overall these substantial increases in the number of avoidable cancer deaths are expected to result from diagnostic delay. And they ask for urgent policy intervention to help to manage this backlog. Otherwise, these figures are just going to increase over time to much higher levels. So going back to my own story, I just want to say a little bit more detail about how I progressed from noticing my change in my breast, meeting my primary care and breast cancer team, and how we worked together through my journey. So I arrived back last August 19 from a trip to Australia where I'd been undertaking academic work. I was feeling ready to start the new academic year, and in September my daughter told me that she was pregnant, expecting our first grandchild, and of course I was thrilled. And then just 2 weeks after that, I noticed that I had changes in my breast. And these weren't typical changes. I wasn't expecting to find a heaviness and a density in my breast, but that is what I found. It wasn't a typical lump. It was just a change in texture. And then I noticed I had dimpling around the skin when I looked in the mirror. And I immediately knew something was wrong. So I called my GP, and I was so fortunate I had an appointment within 2 hours. And during that appointment, we shared my symptoms and we talked about the uncertainty. But the thing that was really, really difficult for me during that consultation was really, although we were sharing the symptoms, I knew that I must have breast cancer. And my biggest fear was how I was going to tell my daughter, my newly pregnant daughter, expecting her baby and needing her mother, perhaps more than any other time in her life, that I was diagnosed with breast cancer. And I just found that heartbreaking. So my GP made an urgent referral for an appointment to the breast cancer clinic within 4 days. So I was well within that 2-week rule. I was very lucky. And then we go through the process of the diagnosis of breast cancer. And all of these things that are listed on the left are typically what every woman goes through according to the protocol. And most of this takes place in England in the one-stop clinic, according to NICE guidance. But the thing that struck me from the quote that I put here from Rebecca Johnson, she said that the mammogram gave way to the sonogram, which gave way to the biopsy, which gave way to the MRI. It was like hitting the plus sign on Google Maps over and over, getting closer and closer to the target. Soon we'd be able to read the writing on the garbage cans next to the back door. And that is how it felt, getting closer and closer to this badness, this garbage inside my body that I just wanted to get rid of. I just wanted to have the surgery and get it out. And then you wait. And you wait. You wait for the diagnosis, for the CT scan, the surgery, the follow-up, the start of chemotherapy, radiotherapy, and the end. And every wait is like eternity. I wasn't told the results of my CT scan until about 20 minutes before going to theatre. I didn't know up to that point if I would live or die, if a mastectomy was the right course or not. It was clear that waiting to the last minute to hear the news was an awful experience. The consultant hadn't realised that nobody had told me. And then there's the importance of self-agency. To be able to accept the diagnosis, to make decisions, to take informed risks, put trust in the clinical staff and have a voice in your own care, you need to have a sense of self and an internalized integration of the mind and the body. This integration is unparalleled in the externalized world of the healthcare system. And the arrival of COVID-19 throws what we once knew into uncertainty and chaos, disintegration, and feeling shattered. So COVID-19 brings risk, but it brings fear and uncertainty. And overnight, from the 16th of March, I became extremely clinically vulnerable. I had a letter from the government that told me what I had to do to protect myself. And that meant that I became completely isolated. I more or less had to live in one room, sleep separately from my husband, have sanitizer all around the house, wash all the surfaces, keep everything clean. It was summertime, so I was at least able to go out into the garden. But it was a very difficult and isolating experience. And then I started chemotherapy and unfortunately developed neutropenic sepsis, which was also a terrifying experience that led to hospitalization during COVID-19 when everything was still very uncertain. PPE was still short, staff were very stressed, people didn't really know what to do, and I was immunosuppressed. And following that, I was looked after by the virtual respiratory hospital, which was also a very strange experience because although my COVID-19 test was negative, I felt as though I was being treated as a COVID patient as well as a breast cancer patient. And all of this led to a sense of hypervigilance, being so careful the whole time, not knowing where or when I might encounter the virus, which led to extreme anxiety and also moments of depression. But this is where it was so important that I had my breast care nurse, access to that person who understood what I was going through. Contact with my GP was really important, and also my psychotherapist who was with me the whole way through. And so the importance of contact with others like me also became very important. And we have a great charity in England called Breast Cancer Now, which enabled me to be in contact with other women who were also going through this at the same time. One of the things that I felt very strongly was a sense of being divided. I was a divided self. I was deconstructed by surgery and then asked to think about being reconstructed. And all of this struck me as being a very disintegrating time in the period of my journey. So I describe myself through the surgery as being cut and then being poisoned by chemotherapy and burned by radiotherapy. And all of this led to a kind of disintegration of mind and body. I felt a complete loss of myself, a loss of agency, and lost in a system of protocols and prescriptions. Going through chemotherapy must be the most lonely and difficult experience. I had no idea until I went through this how hard it was and how it makes you feel. I had a whole range of very distressing symptoms, one of which was neutropenia, which was severe and led to neutropenic sepsis and my hospital encounter. And during that time, I started to think, I kept a journal, which was also a way of trying to find myself and trying to keep myself whole. But I decided that I would investigate my survival estimate, which when I looked into it, I had a prognostic score of 6.94, which indicated that my 5-year survival would be 50%. And this was a huge shock to me. My surgeon had told me that he would cure me of cancer, and I'd held on to that. and then to find that I might not be alive within 5 years, or at least I had a 1 in 2 chance of being alive, was deeply and profoundly shocking. My oncologist advised me that this could be increased to 75% with the adjuvant chemo and the radiotherapy, which was an improvement, of course. But then when I had my information back from my GP, I was told that it was just hard to know. And so I have found this very difficult, that I may not be around to see my baby granddaughter growing up, or to be here for my children and my husband. So within all of this, the importance of human contact was enormous. And it made me think about 3 things. It made me think about, how can we get beyond the mask? How can we be beyond the screen? And the importance of being with and alongside when we're isolated due to this terrible pandemic. So being beyond the mask, well, we can get behind the mask, although the mask hides our facial features, can to some extent hide the interaction that we need to have with the people around us. I did find, particularly while I was doing my hospital admission, that there is human contact over the mask. At one point, one of my consultants looked at me across the mask at a point where I really felt so ill. I just didn't know what was going to happen. And he said to me, you will be all right. We are going to look after you. And I was all right. The clinical staff did look after me. I didn't die. And on another occasion, a nurse came to administer my IV drugs, and she sat with me and looked over the mask. And we made eye contact, and she just told me about her little girl that she'd brought over from India just 3 months before the pandemic had started, and how she'd had to leave her little girl at home alone with her grandmother, and she couldn't go outside to play. And I told her about my pending granddaughter, and we just shared that very human moment, and it was incredibly important. I've never forgotten that nurse, although I'll never see her again. And then similarly, all of my follow-up since hospitalization has either been on the phone or on the screen. And so I've had to find a way to get beyond the screen, to make that contact with people, with my GP, with my oncologist, with my physiotherapist, and with my psychotherapist. It's difficult, it's hard having these interactions through glass, but I found that it is possible. And it is possible for people to be with you and alongside, despite all of these barriers. And then there's the importance of caring, of the family, of friends, and therapy. The importance of being outside and with nature. So over the summer, I was able to go out into our little garden and find the warmth of the sun, of vitamin D, where there was growing evidence of it having some protective effect against COVID, of being with friends and family at a distance in the garden eventually. And the importance of all of these people being there and around me when you feel lost and afraid and disintegrated was just enormous. And knowing that you're not alone, even when you feel alone. And then the ending of treatment. I had 15 sessions of radiotherapy. As I say, I felt cut, poisoned, and burned. It was medieval. That's how it felt to me. And I had this strange experience during radiotherapy of seeing myself in a ghostly mirror. It was the X-ray machine, as it went over me, was reflective. And there I was lying on the radiotherapy table, half naked, and looking up and seeing this disembodied self looking down on me was a very weird and strange sort of out-of-body experience. And I went through that 15 times. And then on my last occasion, I just sat up and I said to the radiotherapist, well, is that it? And she said, yes, have you got your follow-up appointment? And then I just walked away. And I walked out into a searing hot car park in my mask. And I just wondered, is anybody there? I've got to the end of my treatment, and it felt like a complete anticlimax to everything. So I've told you all of this because I wanted you to understand the importance of integration for the patient when we're thinking about integrated primary care. So to go back to the starting point of what is integrated primary care, and the importance of the patient's perspective is at the heart of any discussion about integrated care. Achieving integrated care requires those involved with planning and providing services to impose the patient perspective as the organising principle of service delivery. So I wondered, how can this be achieved in times of crisis to enable the patient to experience care that is integrated and to feel integrated and whole as a person? So these are some of my ideas about what a model for person-centred integrated primary care could look like. And I think first and foremost, communication is at the heart of this. Establishing good communication from the very start between the patient and the GP, between the patient and all of those other parts of the primary healthcare system, of the breast care clinic, the oncology department, the chemotherapy department, but also between all of those clinical staff with each other. It's really important that clinicians talk to each other as well as talking to the patient and sharing all of the records so that the patient doesn't have to keep repeating themselves. Ensuring that your patient is heard and understood. That very early experience of me just not knowing how I was going to tell my daughter. I just needed to be understood at that moment, that that was my greatest fear. And then the follow-up with the clinical guidance to ensure that you have that rapid referral, the 2-week rule, and all of the protocol that follows on from that is really important. But what is also important is the patient understanding the rationale, why you're doing it. Sharing difficult news and patient reactions to that with compassion. It was very hard for me not knowing what my prognosis was going to be, and learning that the tumour that was originally thought to be 4.3 centimetres was actually 10 centimetres was a huge shock, and that led to the discussion around my prognosis. So sharing that news with compassion, terribly important. And recognising that self-agency might be compromised through fear and loss of sense of self. You don't know where to turn. You fall apart, and you need that recognition. Discussing treatment decisions at every stage, and including that really important end of treatment. I think sometimes that gets forgotten. Involving friends and family all along the way. That's essential. Engaging with the multidisciplinary team, with oncology, with the nursing team. So important that primary care and all of these other parts of the system engage with each other as well as with the patient. And then it's so important to be accessible. During this crisis, it's been so difficult for people to see anyone face to face. So we need to be accessible through the technology that's available to us, and to make the most of that, be it the screen, be it the phone. We need to find a way to get beyond that so that we are accessible to the person. And finally, to be authentic. This has been the most difficult crisis for any of us to manage, whether we're healthcare staff facing it every day with our patients, or whether we are the patient. It's so important to share the difficulty that we've all encountered during this time with each other. And I believe that these are some of the features of an integrated primary care that also contribute to integration for the patient. Thank you so much for giving me the opportunity to share this journey with you. I think it's been a great moment for me to be able to share this with so many people. I hope that you've learned something from it, and I'm really happy to take any questions or comments that you have. Thank you.
Yes. Could you hear me?
Yeah, yeah.
Okay, Sally. It's hard to take over now after your speech. So thank you so much for sharing your intimate and extraordinary experiences with us. Really, it's a big moment. And I'm sure we are all really impressed and we are touched, deeply touched from your speech. Thank you so much. And thank you also for your words, like being cut, feeling cut, poisoned and burned. It's like poetry, you know, and so important that someone is speaking about this. Okay, we do have literature about doctors as patients. I know some of that, but I think we have too few. We have not so much literature about nurses and other professionals as patients. So this is really important to hear their voices. So I see the first comments in our questions. Yes, everybody can follow and understand the feelings of being lost in the systems. But Pieta is asking, do you feel that your professional situation helps you anyway for surviving this?
Thank you. I hope you can hear me.
Yes.
Good. Well, thank you everyone for listening and for your questions and comments. I deeply appreciate it. I think having a professional background has to help in some ways in terms of navigation through the system. But at the same time, I think that when you become a patient in this kind of, particularly during this time of COVID, where none of us really knew what was happening or how to manage it, especially back in February, March time. I'm not sure that being a nurse was particularly helpful. I felt that I wanted to be treated like a patient. I actually said to my consultant at one point, you know, forget who I am, forget my title, just treat me like a patient, because I felt pretty helpless at that moment. So I think, yes, it helped me to kind of understand some of the protocols and some of the language, of course, but it didn't so much help with how I felt, if that makes sense. And I needed that, those kind of people around me to help to guide me through it from a much more sort of personal and personalized way.
Yes, so just being a patient and not a professional in this particular situation.
It's really important to just recognize what that means, just being a patient, and how you respond to that, for me was really important.
Yeah, knowing both sides sometimes is a disadvantage either. Also, when you think about all the process. Sally, this is really very touchy, but on the other hand, we have learned a lot of I think for myself new um, details. To be saying detail is not a bad way, but I think this is very important to hear it from someone who is coming professionally from the primary health care. So I think there is another question here, and Bernard is asking, how would you open a conversation with the patient, or which screening tool conversation would you use to engage with patient in order to improve mental health and psychological support, as patient might not want to talk about their suffering?
I think that's probably one of the most important questions. How do you start that conversation with someone? And I think it has to start from a point of putting your own ideas and preferences to one side and really thinking about what might it mean to this patient. And the thing is, we don't know, as professionals, we don't always know what is the thing that is most important to the patient at this moment. And I think, as I said in the talk, for me in that moment of seeing the GP, the most important thing to me was, how I was going to tell my daughter. I was so afraid of, her reaction in the early stages of her pregnancy. That was uppermost in my mind. So how do you start that conversation? Well, I think it has to be by having, a really kind of compassionate stance and being able to be very open with the patient, and to say, to be able to say, I might not understand at this moment how you feel, but how can I help you? How can I help myself as a professional to understand how you feel at this moment? And what are the things that you would like to think about more and to talk about more? And I think if people can be, as open as possible, given that, many consultations are limited by time, we know that, but there does seem to be more time in the cancer consultation, because there's been a lot of work done around the importance of giving people time. But just to really kind of focus on what matters to the patient at that moment, I think is where the conversation needs to go, rather than, for example, I did have a very difficult conversation, which I didn't talk about here, but about having breast reconstruction. I wasn't interested in breast reconstruction. I wanted to think much more about what all of this meant for myself and for my future.
Yes, this is. Oh, sorry, I interrupted you.
No,
This is answering the next question from itself, because someone asked how we can teach or improve the communication skills to doctors, but you answered it already, because you explained that we have to be maximum patient-centered, without a schedule in our head what to talk next and what is the what theme it is, but would be really open and patient-centered. I think for our teaching, which will be very, very essential.
I think so. And I think that, for me, the key word here is empathy. And, you know, it's a very hard skill to teach. I think you can only develop empathy by actually being with patients, being with, you know, other people around you who are going, you know, going through something, and by reflecting on your own experience of how you might respond, how you might feel, and really trying to share that with patients. And I think this is something that I think is really important in teaching medical students and all healthcare students, is to understand what empathy really means.
Yeah, this is some colleagues are mentioning this is a very intense story and in wound care, and it's better not to have the academic view, but a personal story from an academician and also a primary care specialist. So this is very important according to some colleagues who made the comments, which is really, I agree. And one of our colleagues, Mark Alama Ramos, is saying that, thank you for sharing your story. I think we need to improve in showing empathy and speak in a more understandable way to our patients. How do you think we can improve our communication skills as doctors?
Mm.
This is the question, because you were on the other side also.
Mm.
Maybe.
You know, I think to me, it goes back to some of the things I've already highlighted. But I think sometimes in medical education and in other parts of the healthcare practitioner education, we go into it assuming that, you know, the first and most important thing is understanding clinical skills, understanding, you know, the body and the problems of pathology and how to make people better. But actually making people better is communicating well with them. And to my mind, communication should be at the forefront of medical education. You know, before we start to think about some of the more clinical side of things, let's think about how we talk to people. And I think that can be done in all sorts of quite creative ways. I mean, there are some very good programs of communication skills teaching around, but, you know, maybe even you know, encouraging medical students to just go and talk to somebody in the community and then come back and sort of keep a reflective diary, or, you know, some of these sort of simple techniques that can really enable, you know, a young student to think about how they talk to people, I think would be a really good start. And I know some schools do that sort of thing already, but it's having self-awareness, I think, of how we talk, but actually how we listen. How we listen is what is really what communication is about.
Yeah, this is very important. And another very short question from one colleague. He says that, did you get support from your colleagues? Very short.
Did I get support from my colleagues?
Yeah.
Yeah. I mean, you know, I had a lot of support all around me from you know, from my academic and clinical colleagues, you know, lots of support. But I think sometimes even amongst your colleagues, there's not always that depth of understanding of how disintegrated you feel inside. And it's a very difficult thing to share openly. And in a way, you find yourself wanting to protect your colleagues as well from, you know, how bad it can feel sometimes. So yes, they were always supportive, but it's about the relationship that you have with each other and how you share things between you that makes the difference, I think.
And would you please just ask one question which you have been?
Yes, there are so many comments and so many questions. It's yes, we have to reduce. It's so a pity.
But as a woman, maybe
yes.
you can choose much better than
One young colleague, I think, she says we are empathic, but we are also a bit afraid of burnout. If is it okay if you do a little comment on this?
You know, I think this is really really critical for us to understand. You know, when as professionals we're, you know, having to develop these kinds of relationships with patients who are, you know, very unwell and facing very uncertain futures and having to share very difficult news. And you're doing that in an environment where we have an unknown virus and a pandemic that feels as though it's out of control. You know, people are going to start to feel burnt out by all of the anxiety and emotional response that incurs. And I suppose the way to deal with that is not easy. I mean, but I think sharing with each other, and that's why I talked about being authentic, because I think if we try to hide behind what's happening by, you know, a professional persona or a kind of a mask or a screen, you know, we can hide behind those things, but it also belies how, as professionals, people can be feeling. And I think it's really important to be authentic with each other and to really recognize that people are going through very difficult situations, you know, nationally and internationally, especially now. And we need to have support mechanisms for professional staff to help them to prevent that burnout and to look after themselves.
Yeah, this is. I was just trying to collect the questions in order to send them to you, because there are questions and comments, but we don't have time now to ask all of them. Sally, this is really very how do you say, touchy, but also we learned a lot, I think. And my colleagues are asking a lot of questions. Still, they are asking. I think that shows that we don't know anything about those kind of feelings which patient lives with us. Thank you for sharing. Anne, last word is yours.
Yes, the same. It's such a pity that we couldn't answer all these huge questions, but perhaps you can read them later on or answer your personality. So once more, thank you so much, Sally, for your speech and for your impressive thoughts and words, and all the good for you, for your future and for your family. Stay healthy.
Thank you.
Stay healthy. Stay healthy. See you soon.
Thank you. Bye-bye.
Bye-bye.